Welcome to today's video. We're breaking down care for older adults, also known as COA. We're also going to discuss on how abstractors, coders can also find the right documentation so that they can apply the correct codes and support HEDIS star ratings for the measurement year of 2025. I hope you enjoy it, and if you do, please like, comment, and subscribe. I hope by the end of this video, you'll understand the COA measures, know where to look in the chart, correctly apply the CPT codes, and learn why some components like pain screeners are still valuable even though they are retired. COA has three main components. You have the functional status assessment, medication review, and historically pain screening. For the measurement year 2025, pain screening is retired. COA measures ensures older adults get key assessments, functional medication, and historically pain screenings. All of these are to support their quality of life. The eligible populations are members 66 years of age and older as of December 31st of the measurement year. And as mentioned before, the percentage of adults 66 years and older who had each of the following during the measurement year. So again, you have the medication review. The provider type must be a prescribing practitioner or a clinical pharmacist. And then the functional status assessment. All of these can be documented through admin data or medical record reviews. The COA components for measurement year 2025. Again, you have the functional status assessment, medication review, and the pain screening is currently retired for now. But best practice, we do not know when it may come back, so we will still document and code pain screening as well. Best practice and measure tips, care of older adults, FSA, which is also functional status assessment. In order for you to be compliant with the FSA component, a complete functional status assessment must include one of the following. We must ensure the functional status assessment is comprehensive. It's covering either the ADLs, which is the activities of daily living, or an instrumental activity of daily living, not just a single issue like a leg pain. The documentation must show the full assessment and the date. The date must be on the progress note or the assessment. It is okay if it's like if it happens over several visits, but we cannot count the assessment done during an inpatient stay, so no hospital visits. Using standardized tools like the Barthel Index, CATS Index, or PROMIS can help ensure completeness. Be sure to review notes carefully and avoid missing these key details when abstracting for measures. Functional status assessment, use CPT CAT 2 code 1170F. When a functional status assessment is documented, this includes evaluating daily activities, mobility, and cognition. Best practice and measure tips for medication review, which is also MDR. For the medication review, make sure we have both the medication review and the medication list. They both need to be documented on the same visit, or confirm if the patient received TRC, transitional care management service, within that year that they did a complete medication review reconciliation. Um, a signed and dated medication list alone also meets the requirement, as the signature shows the provider reviewed the medication. The list can be simple, just medication names, or more detailed with dosage and frequencies. It should include over-the-counter drugs and supplements. Keep in mind the patient does not need to be present for the review to count. So even a chart review qualifies. You can also do a televisit for COA in general. It's so simple. This measure, no one should ever get less than a 5 or 4. Medication review. For medication review, document the medication list 1159F, and ensure the prescriber or pharmacist has done the medication reviewed. 1160F. Remember, the MPI is required. Pain screening, again, this measure has been retired for the measurement year of 2025. However, it is still valuable for internal quality monitoring, and we do not know when it will come back. So, best practice is to continue to use those CPT Cat2 codes for pain present, which is 1125F, no pain present, 1126. It's not necessary, but we never know when it may come back. So best practice is to continue to support the progress note and code whatever is listed internally. Where to find COA components, especially once you receive that scorecard and you have gaps on the scorecard for the COA, you have the medication listed, but you don't see the reviewed. And I'm quite sure these are being done on a daily basis whenever the patient is being seen. So you can find the COA components in the claims data, the EHRs. Most of the time, when the patient comes in the first time for the wellness visits, most providers document all those COA components on the first wellness visit. You can also check the pharmacy notes as well. As a coder, you should review all of those sources when you are reviewing a HEDIS scoring card. Um, when you're abstracting, check the history and physical sections for functional assessments. Look for the medication list and a provider or pharmacist review the MPI. Most of the time, if you see a medication list, the provider has reviewed it. Just make sure that it is signed. You can check the ROS or the exams for the pain screening. Again, we know that is not required for STARS this year, but it is best practice. Where abstractors find COA components, by the time it's time for the abstractors to go in and review the medical records, they should have already checked the claims data to see if it was actually completed. Um, as I mentioned before in the previous slide, you can find the COA components in the claims data, um, the EHRs, of course, and then the first place that I would recommend abstractors or coders, whoever who is looking for these components, is to check the annual wellness visit. Most of the time, as I mentioned before, the providers document everything, all the HEDIS measures in that first visit of the year. So you're going to try to look at the annual wellness visit. You're going to check the history and physical section for ADL status, mobility or fall risk notes, functional assessment documentations. For the medication, you're going to check the medication list section, check for updated medication lists, make sure that the provider or the pharmacy is the one who reviewed it and it's signed. Um, I'm going to discuss the pain screening again, although it is retired, but it's good internally, quality of care. So for the pain screening, you'll check the vitals, you'll check the ROS. Most of the time, there's a pain scale documented, present, absent, or just a scale like 1 to 5. That's where you will be able to abstract that pain screening. Um, You can also check the billing system, claims details. This is more for coders just to audit, especially when you receive that scorecard and you're like, we submit these F codes on every single claim, especially for Medicare Part C. You all should be documenting F codes every single time you're coding or submitting claims. The F codes for Medicare Part C should be there. Um, Best practice when you're reviewing and abstracting, you are to check multiple sections of the note. Confirmed who performed the medical review. It should not be the medical assistant. It should be the provider. There needs to be a signature there. on the note. You're going to confirm the CPT Cat2 codes, make sure that the NPI is also captured. Um, Again, you're going to continue to do the pain screening because we do not know when it will come back. And if you do this, you all will pass with flying colors, especially for COA. COA is probably the most easiest measure of them all. My favorite as well. Should you still use pain screening codes? I know you all are tired of me keep saying the same thing throughout this video, but yes, you all should. For internal care monitoring, for quality of care, we should still be using those CPT codes. Although pain screening won't impact the star ratings, I highly recommend to continuing to code and document that internally just to monitor the patient's well-being and to inform clinical decisions when it comes to that time. COA measure exclusions. These are required exclusions if you are trying to be excluded from this measure for a particular patient. Members that are in hospice or using hospice services anytime during the measurement year, they can be excluded. If the patient is in any inpatient setting, SNF, rehab, um, hospital, then these services are excluded if it's within an acute inpatient setting. And of course, any member who died anytime during the measurement year, they are also excluded. The key takeaways from this video, you want to make sure that you focus on capturing the functional status and medication review with the proper codes 1170F, 1159F, 1160F. Make sure that the NPI is present on the claim. Document the pain screening for internal tracking. Accurate abstracting improves care delivery. It closes the care gaps and it strengthens the plan's performance. So it is very important to make sure that your provider is documenting properly, no contradictions. Thank you for watching. Like, comment, and subscribe for more coding quality measure tips from us. And if you enjoyed it, share it. We are not asking for much. If you would like to see different videos, please drop it in the comments. We will definitely review and do our best to accommodate whatever you're asking for. Thank you again and enjoy.